So very good afternoon to you all. And let me talk to you on patent strabismus, its management. I have no financial interest in this presentation. So this is a 14-year boy who presented with complaints of outward deviation of the eyes since childhood. Visual acuity was 6/9 in both the eyes. There was no abnormal head posture, and when we see this is having a right exo, and when he is looking up and in down gaze, you see some deviation of the exo in the up gaze, and there is a ESO in the down gaze. So we say that he's having some type of a patent strabismus. So we put it as a V-exo in this cases. So what is basically this patent strabismus? It's a horizontally concomitant strabismus with a vertical incompetence which is there, which is put as a pattern like A or a V pattern, which is quite common. So the incidence is around 15 to 20% in horizontal strabismus. And you can, if you see this case, you have a V pattern, which is exotropia is more in the up gaze, and in A, if you see, ESO is more marked in the up gaze. Now you have other patterns like X pattern, Y pattern, and a lambda pattern. So coming to the clinical workup, very important is you have to see in the 9 gaze and look for any abnormal head posture or any chin depression in these cases. And in this case, what you are finding is a V pattern exotropia. So this classification of eye movement abnormalities and strabismus, National Eye Institute sponsored program which was there, they always said look for the over elevation or depression in abduction, and that will give you an idea of whether there is a superior oblique overaction or a inferior oblique overaction. So measurement is always done in up gaze and down gaze, and with an accommodative target that should be kept in mind. And if you see the difference of deviation, which is measured in 25 degrees up gaze, that is chin down, or 35 degrees down gaze, that is chin up position. If it is more than 15 PD, that is a V pattern, and 10 PD, it is a A pattern. So you can use this loose prisms, or you can use the prism bar. And very important is always look for the torsion, and you take the fundus photograph to help you to look for the torsion. So why do this happen? The risk factors are craniostenosis, superior oblique palsy, and patients who have thyroid diseases with inferior oblique recession. And as such, the etiology is still debated upon, but the hypothesis is that there is a mechanical or there is a neuronal hypothesis. For mechanical hypothesis, the things is that abnormality in the extraocular muscle pulleys, which has been postulated by Dimmer et al. Now coming to the neurological hypothesis, there is a loss with the abnormal torsion, or there is the abnormal supranuclear circuits in this case. Common causes, as we usually think, is the abnormality of the muscle action of the horizontal or the vertical muscles, anomalies of the muscle insertion, that is desagittation based on the superior oblique insertion. What is coming up new is the anomalies of the muscle pulleys you have to look for, and association of the orbital configuration in most of the cases. So if you look at this picture, mainly we have to be very clear that is a V pattern in a craniofacial syndrome which we are seeing, and the management is mostly surgical. What is the timing of the surgery is, if you have an abnormal head posture and the strabismus is interfering with the development of the best BSV, and the difference if you see in up gaze and down gaze of more than 15 PD has to be undertaken for surgery. So before taking up, you have to give a full correction, you have to do the amblyopia therapy, and always take for the care of the post-operative care you have to do. Now what are the choice of surgical procedures in these cases? And if you see that there is a mainly the horizontal muscles can be tackled if you don't have oblique overaction, and you can do a vertical displacement in these cases. Now, if you see there is a oblique overaction, then just taking care of the primary won't be helpful. So you have to take care of the inferior oblique overaction in V pattern or superior oblique in A pattern. This is a normal teaching for all the students, which we say that MR should be down and the LR should be up in most of the cases. And if mainly if you don't see any obliques, then you can tackle the horizontal muscles in that go. But if the oblique overaction, that has to be done, taken care of. So horizontal muscle recession or recession, look for the deviation in the primary position. Now collapse of the extent of the AV pattern is basically if the obliques are overacting, the obliques has to be weakened, and that can take care of 20 to 30 prisms. You can do a differential R and R. You can do a slanting recession. As a rule, 1/2 tendon with the width of the vertical displacement results in 10 to 15 PD of the pattern correction. So this is from Pradeep Sharma sir. He has given a pattern surgeries in which patterns to take care of. And one thing we have to understand, this is another thing, the torsion in AV pattern will be taken care of if you do a posterior tendectomy of the superior oblique for a A pattern to avoid the cyclotorsion. So that has to be also kept in mind. So this is a preoperative case who presented to us with a V pattern without an inferior oblique overaction. So this is a surgery in which we went through, and we did a limbal based insertion in the peritomy in these cases. We hooked the lateral rectors. So be careful to release the lateral rectors carefully, and so we are doing a recession in this case, and since it was 45 prisms diopter, we took around 7 millimeter. So that is what is the thing here. And so be very careful when you are doing this scleral incision, because we don't want perforation. So your needle should be 3/4, you will be holding it, and here we did a displacement in these cases. So LR up and MR down in these cases. So this is a recession which we have done for the LR muscle. And so this is the MR which we are resecting in this case. So after completing, you close with a 6/0 Vicryl, and your case is over in this. So this is a video which so this is the poster picture of the patient who presented with a V exotropia, and she's quite fine both in up gaze and down gaze. This is another boy who presented with more than 50 prisms with V pattern, and this is the first week post-op of the case, which also did well which did not have an inferior oblique, but did well in these cases. But if you are having an inferior oblique, you have to tackle the inferior oblique in that cases. So the take-home message is primary and reading positions are very important, and a large AV pattern are associated with the oblique dysfunction. So inferior oblique weakening will be correcting 15 to 20 prism diopter V patterns, or you have to do a bilateral superior oblique tenotomy. And if no oblique dysfunction, tackle the horizontal with transposition, and complications should be taken care of, and keeping in mind the torsional diplopia or superior oblique palsy, which you can itself make. So thank you for the presentation.
Thank you. It's a very interesting presentation. I just want to say a few things because we're short of time. One is that once you are torsion and patterns are one may cause and effect.
Yes.
Some people say that pattern is causing the torsion, and some people, there is also evidence to say that torsion is the first thing to come in, and that is causing the pattern.
Yes.
Another thing is that in congenital or situations or concomitant situations, torsion is not going to make much difference. It is only in the acquired conditions where you have a pattern like superior oblique palsy, where torsion can be very troublesome to the patient. So another thing, if you are transposing lateral recti and medial recti, horizontal recti, this is going to worsen the torsion. So if you are trying to treat the pattern, torsion will actually get worse, because like if you put, you suppose you have an exo with pattern, V pattern, there is an extorsion.
Yeah.
Now if you take the LRs up for V pattern exo, let's say, for example, this is going to create more extortion. So that has to be balanced. But by and large, we look at the deviation and not at the torsion.
Yes.
So we also have to choose the procedure what we want to do. And if it is more than 15 prism diopter difference, then you by and large need to touch the obliques. But you must always see that there is overaction, underaction, whatever you are trying to. If there is no overaction, please don't touch the obliques because they are dangerous structures. If you do undue surgery, they are not going to forgive you. So that is, I think, very important message. And if you have an acquired strabismus with torsion, that is subjective torsion, that has to be treated on priority. That is, I think, if there are no questions, we move on to the next talk. Yes.
Cases where sometimes if the pattern deviation is missed and a simple R&R procedure is done.
You should not miss pattern, because if you miss pattern, one is that pattern will not get treated, and this will also have effects on the outcome. The results will not be appropriate. So it is very important to detect and assess the pattern so that your results will be optimum. Otherwise, it will end up with an overcorrection or undercorrection, and patient will be unhappy and he will not come back to you, and you will get bad name.
Like in one case, there was an exotropia and the primary correction was good. But I did an R&R procedure, but in the post-op, the eye was a little bit hypertropic. So I thought that maybe I missed the pattern deviation or.
This was an exo.
Yeah, it was a case of exo.
Exo, quite often a good number of about up to 50% of exo deviations can have little hyper. That is reported cases. So it all depends. You must look for that hyper deviation and look for reason also, because at times there may not be any obvious reason. At times there could be that there is an asymmetrical infraoblique overaction or supraoblique overaction, or there is an acquired condition, or there is some pulley problem. So there are a lot of issues there, but you must, what is important is to detect them before you do surgery, because if you have not detected, then you will not be able to manage. So it's very important to keep these things in mind, that if there is a vertical, you must know what is it. Like if you could have just infra-placed those recti, if it was a hyper, that would have probably corrected. Till about 10 prism diopters you can correct by infra-placement or supra-placement, depending upon the situation. But if it is more than that, then you need to touch a cyclovertical. But then we should know what is causing that deviation, because if you touch the wrong cyclovertical, again there is going to be a problem.
And so if it is just 5 to 8 prism diopter, we can leave it. We don't need to worry.
No, you should not leave. Vertical ones don't forgive you. About 2 to 4 prism diopter they can correct. Then you can transpose those horizontal recti a
So
bit.
in my case, where post-op there was around 8 prism diopter, the eye was a bit hypertropic. So it can be left, or do I need to?
I think you need to look at it. Is if what is it, you must need to look at binocular status and those aspects. If there is, because this will prevent fusion. A diopter. Pardon? Emblyopic. If it is emblyopic, you may overlook it. If it is sensitive kind of deviation, you may overlook it, but it may increase. But that is, you keep them on follow-up and keep looking at it. I think no need to do a surgery for 8 prism diopters in an emblyopic eye. Vision is worse than 660 or so, or good.
So it was 1 meter field.
That is sensitive deviation. They usually go up because of primary infraoblique overaction. So that must be the reason. You must have looked at that. As the eye goes into adduction, it will rise. So that you should have checked earlier. So it should be a lesson for future. You know, see, we also learn from our mistakes. That is very important to keep in mind. At your stage, you are younger people. So try to learn from patients and teachers and books. So that learning is very complex. It is multi-dimensional. It is not unidimensional. Good question. Thank you. Dr. Gogote will be talking about re-surgeries. He is quite busy. So we have.
No, sir. Thank you, Professor, sir, and distinguished audience and speakers for giving me an opportunity to speak out of turn. I was given actually 2 topics, when not to operate a squint and to do squint re-surgery. Now, since I'm speaking in a room full of strabismologists, I think, well, we all know this, that when there is a varying degree of strabismus, or when the strabismus is of a recent onset, it is always better to wait and, retake the readings after 3 months. An intermittent exotropia, because if the Newcastle score is less, if the stereopsis is good, we have seen that early intervention can lead to a subsequent esotropia. All of us have come across patients who are operated pretty early in life to preserve their binocularity, but if it is intermittent, the binocularity is preserved as it is. Of course, medically unfit patients as surgeons, we are very enthusiastic in doing surgery, and for cataract surgery, we can, disregard the fitness that much, but that's not the case, especially when thyroid levels are varying. In neurological cases of strabismus, when it is of a recent onset, when it is associated with a stroke, it is always better to wait. Again, a recent non-concomitant strabismus, it is better to wait. Similarly, for microtropias, or this is what we always tell our students, when there is no strabismus in the primary position, we know there are exceptions like the Duans, the Browns, or the primary inferior oblique overaction. But generally, if there is no strabismus in the primary position, do not operate. Even recent consecutive strabismus, unless it's a lost muscle or a slipped muscle, which must be tackled immediately, but if it is a ET after a XT surgery or a XT after a ET surgery, then it is prudent to wait for a few months before reconsidering surgery. Again, if there is a large overcorrection, there is a Cooper dictum to plan and execute the second surgery as if the patient has never had previous surgery. Again, for a treatment of overcorrection, well, do not reverse the original surgery if ET has become XT. Do not undo the recess, but rather you tackle the other eye and do a recess. If the overcorrection is just less than 10 prism diopters, peripheral fusion takes place, and a smaller overcorrection leads to faster reappearance of a normal retinal correspondence. So it's not that bad. Again, of course, if it is an overcorrection which is more than 12 to prism diopters, we will have to tackle it. And if it has happened immediately in a post-op period, if we suspect a slipped or a lost muscle, then of course early intervention is beneficial. The sooner the better. But one of the things we have to understand while doing resurgery is that the dose-response relationship is difficult to predict. So this is where adjustable sutures are a great help. But of course, they need skill and patience on part of the surgeon and faith and cooperation on part of the patient, because we have to tell the patient that even they will have to cooperate to it, and we don't have a very easy, clear-cut answer to what they have. And of course, adjustable suture improve the chances of good outcome, as was seen in a study by Repka in the US. But in our setting in India, the problem is they need a short general anesthesia for children and for uncooperative adults. And the adjustment has to be done on a second post-op day. And a lot of us run extremely busy OPD. So doing one surgery is itself for this, because there are surgeons who do 10, 12 surgeries a day. If it's an adjustable, then each surgery then has become a two-step procedure and has to be done over the second day. And in a lot of medical schools, institutes who have alternate OPD, OT, even that has to be factored in. Perhaps that may be the reason why this procedure has not become that popular in India, even though of course it gives much better result. And there is a RCT from GNSC Delhi which shows that perhaps there is no significant difference as far as adjustable suture is concerned. But there is another RCT from KGMC Lucknow which found that modified adjustable suture is more predictable. It definitely is predictable, but then perhaps some of our strabismologists are already so predictable in their outcome that they feel that we don't need a adjustable suture surgery. But then for thyroid related strabismus, yes, we could need it. And the main pitfall of course, when we are planning a resurgery is that the normal anatomy is disturbed, and identifying the muscle needs experience, skill, and patience. And we have to be prepared for surprises. So this is something that is there even when it's a restrictive strabismus surgery or surgery after a trauma, because again, the normal anatomy is not there. And this is my personal if in doubt, it is better to grade the surgery. But in the morning only, Professor Pandey sir was telling us, no, it is better if we do both eyes together, and to tackle one or two muscles at a time rather than attempting multiple resurgeries. So thank you to the AIOS Scientific Committee for giving me this opportunity. And well.
Thank you, Dr. Parikshit. Very nice presentation. It's a very vast and very difficult area you were tackling. Only thing I want to say that if it is an acquired strabismus, broadly we have to wait at least 6 months. Even
Yes,
if
sir.
like you have a diabetic 6 no palsy. So initially it's going to be quite devastating for the patient, but they have to be told that it is likely to recover. So acquired cases we have to wait. Then you also have to look at what are the patient's problems, because some things may trouble some patient more than the other. Somebody who is a driver, somebody who does near work. So accordingly, as per patient's needs, also one has to see. And about surgeries in children with exotropia, it is better to wait till 4 years of age. But if control is not good, if you think you will be losing binocularity, then you can, and angles are stable, large angles, you can also operate before 4 years. Infantile esotropias, for example, you operate early, because if you don't, you are going to lose binocularity. So the loss is going to be quite phenomenal. So infantile ESOs operate early. Intermittent exodeviations, you must wait till 4 years if permitted. If not, then you can also operate early. Accommodative esotropias by and large get corrected. These days we are doing better more children are having a refraction, so they are not going into partially accommodative esotropia. So good refraction, good glasses prescription is going to take care, and amblyopia part of course has to be taken care of. I think with that, thank you so much, Dr.
Thank you, sir.
Any
Thank you.
questions? Anybody would like to ask anything?
Sir, I want to ask
Yes.
one thing.
Yes,
Sir,
ma'am.
in children, those who are having some mental disability and they present with this exotropias, about them, what do you say? Should we tackle them early or?
No, that is a very difficult area. That is like cerebral visual impairment and developmental delay. So that's, these children are a different cup of tea. They very often have much larger amount of infantile deviations, because the brain has not developed properly. So that wiring in the brain doesn't take place. So with that, they also have to be assessed by the pediatricians and other neurology evaluation. And the treatment, they also tend to get over-corrected. So when you are doing them, try to be slightly undercorrect them, and they may have primary inferior oblique overaction, dissociated vertical deviation, latent nystagmus. Those features also sort of congeal the clinical picture. So they are a very difficult situation. So one should not rush for surgery in these cases. Evaluate them, do a refraction, prescribe glasses. And about hypermetropia, because they are quite often, infantile ESOs are 10 times more common than infantile exos. So infantile ESOs, you should also do refraction. And in young children, because they could also be a component of accommodative esotropia. Even in duets, quite often they are hypermetropes, so you must always refract and correct whatever deviation is because of the accommodative esotropia part. Otherwise, you may correct the whole deviation and then patient may end up in exotropia. So first treat the accommodative part, and then after that only you can decide to operate, and depending, you can do alternate occlusion and all those things for, that's the kind of regime one can follow depending upon when you want to operate. But infantile ESO deviations, catch them young. Exos, intermittent exos, you can wait. And infantile exos are again a very complicated issues. Very often they have craniofacial disorders like Cruzens and all those. We had a case yesterday. So there is a primary infantile exo and a secondary infantile exo. Primary will be like infantile ESO, but secondary is due to other conditions like Cruzens and all those conditions. So they are different as compared to primary infantile exos. But they are about 10 times more common is infantile ESO. There is larger bouquet there.
We had done a large series which was published in the IGO in 2010 on learning disabled children. About nearly 450 learning disabled children. A lot of them had strabismus.
Yes.
So one thing we found, if it's a large angle strabismus and if it is corrected, the children also appear normal, because otherwise they, as it is, they are not normal. They also appear different. So they appear normal, their parents were happy. But again, as sir was saying, operating very young ones is difficult because consent, and because they have many of them neurological problems, the anesthetists are not this. But the flip side is, if they grow too old also, the anesthetists don't like it because the GA dose increases. And the parents find it easier to take care of, say, a 10-year-old learning disabled child than a 20-year-old learning disabled adult. So when we tell the parents, we'll operate them when he gets older, or she gets older, parents saying, no, you do it now or in the next few years, because now we can take care of him. Once he becomes older, we will not be able to do
Once
that.
you align the eyes, the child's development also picks up. This is also known that once you correct the strabismus, they do better. The developmental part also improves. So it is very important. And there is also things like motion vision processing. So whatever binocularity you are able to give at the earliest opportunity, you should attempt that. Thank you so much.
Thank you, sir.
Parikshit, so nice of you. Very nice presentation. And then with that we come to next presentation, that is on the inferior oblique surgeries. I think we thought we have a lot of time, but we are running short of time, I think. You know? So just 10 minutes or maybe less time?
Less time.
Thank you.
Calling me in the teachers of tomorrow sessions.
Sure, sure. So you take 8 minutes, okay? You are with us. What is the list?
नहीं नहीं सर, आपका डेस्कटॉप पे है। नो नो, डेस्कटॉप ओनली है।
स्लाइड उस पर कर दो, छोटा आ रहा है। हाँ, so I'll be talking about rare and interesting condition which is known as skew deviation. As the name suggests, these are skewed, crooked deviations, and if you don't look for them, you will miss them. So what are these skew deviations? It's a vertical strabismus caused by a supranuclear disorder or prenuclear disorder. We have been talking about nuclear, fascicular, and at neuromuscular junction, at the muscular junction, but these are prenuclear or supranuclear. So the problem is before the nerve nucleus, and this is going to cause the motility problem. This results from the disruption of autolytic pathways. Now, what are these autolytic pathways? You all know about vestibulo-ocular reflex, that from the vestibule, we have the vestibular nerve, which is going and to the vestibular nuclei in the medulla and pons, synapse there, and the second order neuron will come out, exit from there and cross at the level of the pons, at the level of the sixth nerve nucleus, ascend in the medial longitudinal fasciculus on the opposite side, go till the interstitial nucleus of Cajal. So it's a long way, and if there is a problem along these pathways or adjoining structures, you will have a motility problem, you may have one. So they localize to the brainstem or cerebellum or vestibule, because that is the main part of the brain. The cerebrum part has come later. It is a later addition, you can say, extra baggage. So they are form of the basic brain. Now they are diverse in presentation and etiology, may create diagnostic and therapeutic dilemmas for acquired strabismus, because at times they mix up with superior oblique palsy, inferior oblique palsy, and lot of other things. Now why a skew? Skew is basically the autolytic pathways are a writing reflex. So if there is a problem with autolytic pathways on one side, this creates, they are important for balance. Like, you know, monkeys, and we can all climb trees with lot of finesse. If you look at those spider monkeys in South America, they hang with their tail and they do all kinds of things. You'll find a monkey hitting a tiger also, if you have seen some videos, and going up from one tree to another. So for this you require very good visual acuity, you require very good cerebellum, you require very good proprioception and coordination. So once this balance is gone, if there is this input is asymmetrical, then you will have a skew. This is showing the autolytic pathways. As we said, this is starting from the vestibule, going to the medulla and pons, crossing at the level of the sixth nerve nucleus and ascending on the opposite MLF. So the lesion, if it is before the sixth nerve nucleus, it will be ipsilateral ocular tilt reaction, what we call as ocular tilt reaction, which has three components: the skew, the conjugate torsion, and head tilt. As you can see, the head is tilted to the left side for a left side lesion. But once it is crossing to the opposite side, the same thing will continue. So lesion can be anywhere from this to the interstitial nucleus of Cajal. It's a long way, and adjoining structures can also be affected. This is showing other things which can be affected, like posterior commissure, which will give rise to pretectal syndrome, INC, which can give rise to nystagmus quite often, and of course vestibular nuclei, and superior fourth nerve is also along. So you have third nerve, fourth nerve, MLF lesions. So MLF is will give rise to, what does MLF lesion cause? We have an internuclear ophthalmoplegia. So an INO could be very often associated with skew deviation. So whenever you see internuclear ophthalmoplegia, also look for a skew. That should be one of the messages. This is, we will not go into this detail. You have anterior canal, posterior canal, and horizontal canals, as you all know, and they are supplying particular muscles. The anterior canal supply the elevators, that is the superior rectus and the inferior oblique, and the posterior canals supply the depressors, that is the superior oblique and the inferior rectus. And they are working in push-pull mechanism, that if one muscle is activated, if the anterior canal is activated, posterior canal is going to be inhibited. So it is a push-pull mechanism, and it works in that tandem. Now this just shows that if you have an anterior canal lesion, this will give rise to the superior rectus is gone and the inferior oblique is gone. Now the superior rectus palsy, you can see on the left side, it is going to cause hypotropia because superior rectus is perised and inferior rectus is activated. So this is going to pull the eye down. What will happen to the right side? The superior oblique, the inferior oblique is gone. So the superior oblique is going to act and cause intorsion. There is no antagonizing force from the inferior oblique. So you will have intorsion on the opposite side of the lesion and depression of the same side of the lesion. To compensate this, he will have an abnormal head posture to the hypotropic side. So in the anterior canal lesion, you will have hypotropia and intorsion of the other eye. If you have a posterior canal lesion, the opposite will happen, that the other eye will go hyper because the IR is inhibited, and there will be extorsion because the superior oblique is inhibited, so the inferior oblique is going to cause extorsion. Now looking at this together, there will be a vertical and there will be extorsion of one eye and intorsion of the other eye. Now what we call this? This is, okay, this is conjugate torsion. This is conjugate torsion because both eyes are torted in the same direction. One extorsion, other intorsion, so it is like eyes torted this way or torted this way. Now if both eyes are extorted or intorted, we call it disjugate torsion because both eyes are extorted or intorted. We will see some pictures about that. This is just showing that you can have skew in three planes. One is the roll, where you have ocular tilt reaction, and also DVD. They are basically they share certain things in common. Then you have interoral plane between the two ears, which is going to give rise to primary inferior oblique overaction or a skew, which is laterally alternating skew deviation. Means as the eye is going into adduction, it will rise or fall. and both ways. So eye may fall or rise depending upon if it is a primary inferior oblique overaction or superior oblique overaction. So these are in the pitch plane. What we call as interoral axis is pitch plane. Then you have the yaw plane, which is going to cause torsion. So an ocular tilt reaction in the roll plane, a pitch laterally alternating skew in the pitch, and a torsional deviation in the yaw plane. So these are in the three axis you can have these movements. Now this is showing a typical case, ocular tilt reaction. You can see that there is a tilt to the right side and there is a left hypertrophy. I will just show you next picture, and there is also limitation of, you can see here. This we are doing as part of workup. You have to look at subjective torsion, because as I said, there is going to be intorsion of one eye and extorsion of the other. Very important to look at it, because patients may not complain, but once you put the double Maddox rod, that is the best way to look, and simplest way to look at the torsion is putting a double Maddox rod and looking at it. Simplest way, easily available, so no difficulty. There are changes with the supine position with torsion and vertical deviation in skew deviation as compared to superior oblique palsy, for example, where it does not change. So that serves as a differentiating feature. With these conditions, if you are trying to separate superior oblique palsy from a skew, make them lie down and look at their vertical deviation and torsion, which may get better once the patient is supine. So it is just to differentiate them. We are not going into the detail why it happens, because there is no time in this. Now this is showing conjugate torsion. You can see, you understand what is normal torsion, normal position. You understand that this is lower third of the disc. The fovea should lie along the lower third of the disc, from the lower margin to 1/3 of the disc. Now if it is below that, then we call it extorsion, and if it is above 1/3 to 2/3, then we call it intorsion. Now here you can see that the right eye is extorted and left eye is intorted. So this is what we were talking, that in these conditions you will find that both eyes are torted in one direction. This torsion, this kind of torsion you don't get otherwise, by and large, that one eye is intorted and other eye is extorted. You may have one eye extorted or intorted depending upon if you're dealing with the superior oblique palsy or inferior oblique palsy. That can happen, but this is something which is quite diagnostic by and large. Tilt, some of these can come on tilt also, and they can mix up with the superior oblique palsy or inferior oblique palsy. So we need to keep that in mind, that that is also not going to be the differentiating feature. Now etiologies, as we said, the brainstem, strokes are an important factor in older age group, and in younger age group you have tuberculomas. In our country we have a lot of tuberculosis still, and you do see a lot of tuberculoma. Cysticercosis is another very important differential diagnosis. We have a lot of cysticercosis, neurocysticercosis, and of course there will be other conditions like hydrocephalus, adenochiari, trauma. They are not so common, but keep in mind brainstem stroke, tuberculosis and neurocysticercosis. If you have these, you are likely to end up with a skew. Fellow travelers, I said you can have an intranuclear ophthalmoplegia, you have a pretectal syndrome. If you understand that there is inability to, up gaze is limited, down gaze can also be limited, the pupils are semi-dilated, and there is convergence retraction nystagmus. So this is a picture which happens because of the lesions in the posterior commissure. So because these structures are lying close by, so you may have a pretectal syndrome with a skew deviation. Same thing happens with the INO. You can also have a nystagmus, ataxia and vertigo, because it's involving the vestibular structures, but not in all the cases. Clinical features, we have already said that there is a tilt in the subjective visual vertical, SVV, we will not go into the detail, and there is a conjugate torsion, we have said AHP. Vertical diplopia can be symptomatic. Head tilt is usually negative, but can be positive in some cases. And important, there is no primary and secondary deviation here, because there is no overaction and underaction. So that is one important thing to distinguish from an acquired strabismus, that there is no primary and secondary deviation, which you may find in other conditions. And there is no spread of comitants, because they are quite, they stay as they are, and usually there is no pattern also in these. And a good number recovers with time. So you have to give time, as we were talking in the last talk. Very important to give time when you have an acquired strabismus. Now the differential diagnosis will depend upon it is incompetent or competent, will not. Third nerve palsy, ocular myasthenia gravis, acquired MED, Brown's, and mitochondrial cytopathies. All these acquired conditions have to be kept in mind. Most important to look at is acquired superior oblique palsy and acquired inferior oblique palsy, because these two conditions get mixed up very well with a skew. This is showing the same patient we saw earlier. You can see that there is in the left eye is not adducting fully. There is an exo, the left eye is hyper, and it is not adducting fully as compared to the right eye. Now this adduction deficit is because of the internuclear ophthalmoplegia. As I was saying that he had probably an infarct. He was a patient with cardiac valvular disease, and probably he had a embolus, and which caused the infarct. So you have an INO and you have a skew here. This is showing the conjugate torsion, you can see very well. Another one, you can also have these incomplete presentations, like this girl also has adduction deficit in the left eye, you can see. And if you look at the torsion, the left eye is intorted, but the right eye is not extorted. So it is not important always that both eyes you should have conjugate torsion. It can happen that one eye is intorted, other eye is not there. So you can have these combinations also, which may be present there. This girl had, you can see the big tuberculoma on the left side. This was in the midbrain, in the pons area. You had a huge tuberculoma. So this was the one, if you don't do MRI, you will miss them. So you need to do an MRI in these cases to image them. This is showing another pretectal syndrome with skew deviation. You can see there is upgaze limitation. But तुमने हमें time ही नहीं दिया ना, तो थोड़ा सा time दो ना. You had problems in midway. And we have another talk. I think she has come, or she? Give us 10 minutes, sir. Thank you, sir. Thank you, sir. So this is a pretectal syndrome. Pretectal means that the problem is in the posterior commissure where the upgaze fibers are crossing. So if they are affected there, so you will have an upgaze palsy. You can also have a downgaze palsy. They are a mid-dilated pupil, and there is a convergence retraction nystagmus. So because these fibers are also there, you may have a pretectal with a skew deviation. So this is important to keep in mind. Again, this is showing conjugate torsion here, and you can see here after 6 months and 1 year, the torsion part has improved a great deal. So you need to give them time. Some of them are going to improve, the torsion as well as the vertical. So at least 6 months you have to give them for recovery. This is showing left thalamic infarct. This is older patient, hypertensive. So he had a thalamic infarct, and that gave rise to pretectal syndrome as well as skew. This is another girl, young girl. You see this large ESO in downgaze and EXO in upgaze. And abduction is complete in primary. There is an ESO. Now you tend to think that this is a bilateral 6-nerve palsy or something. But what is happening here? This is a bilateral superior oblique palsy, because there is a V ESO and V EXO. EXO in upgaze, ESO in downgaze. Always think of a bilateral superior oblique palsy, because very few other conditions will produce an ESO and EXO in upgaze. So that's something interesting. And she also had an ocular tilt reaction, as we shall see. Now here you can see a conjugate torsion towards the left OTR. The right eye is intorted and left eye is extorted. All right. Now look at later pictures. After 1 year, the right eye and left eye both are extorted. So what has happened is the skew part has recovered, but the superior oblique palsy, which was bilateral, has still remained. Now both eyes have gone for gross extorsion because of the superior oblique palsy, which was causing V ESO and EXO in upgaze because of inferior oblique overaction. So skew can recover, and even torsion can change from an intorsion to extorsion, and even the extortion part, as you can see in the left eye, has got better. It is not as extorted as it was earlier. This is showing a pilocytic astrocytoma in this case, which was a large one, probably pressing on the superior obliques as well. This is another thing to keep in mind. You can also have an acute acquired competent esotropias, some of these conditions. If you have a brain tumor in a child, if you have tuberculomas, or any other, even after trauma, you can have what is known as acute acquired competent esotropia. A large number are not associated with neurological disease, but some of these may have a neurological disease. And here we had multiple tuberculomas all over. So these are usually caused by cerebellar lesions. So maybe there was a cerebellar lesion in the tuberculomas in the cerebellar part, gave rise to this acute acquired competent esotropia. And you can find this is a large one, ESO, and after treatment, this is also showing intorsion and extorsion, so that shows that this was because of this. So treatment goes, manage underlying disorder, wait for resolution. Prism and botulinum toxin can help. Head tilt and conjugate torsion are difficult to treat. Surgery is mainly on the recti for vertical deviation, so don't be very proactive about surgery. So look at for skews in acquired strabismus, INOs, pretectal syndromes, gaze palsies, acute acquired competent esotropias, include subjective and objective torsion and head position dependent changes in as fourth and fifth step. Very important to look at the subjective torsion in these cases, because that will give you conjugate torsion. So always look at torsion as an additional parameter to evaluate, because we tend to overlook that and we'll end up in difficulty. Suspect them, keep low threshold for suspicion, and order neuroimaging and neurology evaluation, and wait for resolution. If they don't resolve by 6 months, then you need to operate. Thank you so much. I think we have a small talk by sir. Another 5 minutes we'll request you. Thank you, sir. The last session. We'll be talking on inferior oblique palsies.
Sir, can you just, with a couple of lines, take away message from your talk?
Takeaway message from my talk is that whenever you have acquired strabismus, you should always keep the possibility of skew deviation if you are suspecting that this is a stroke, or you are suspecting this could be a tuberculoma or neurocystic sarcosis or after injury, and this can also be with a superior oblique palsy along with this. So this could be a mixed picture. The damage could be anywhere from the ear to the midbrain, and we need to evaluate them and do an MRI and wait for 6 months, look for the resolution, and after that accordingly we need to treat them. Thank you, sir.
We'll start. So thank you, Pandey sir, for this wonderful opportunity. The topic for today would be inferior oblique surgeries. Before we go into the actual surgeries, there are 2-3 things which you need to remember, that the inferior oblique actually originates from the floor of the orbital floor of the maxilla. It runs posteriorly backwards, and where it gets inserted, it is very closely related to 2 important structures. One is the macula and the other one is the vortex vein. So these 2 things should never be forgotten, lest when we are hooking the muscle we can damage these 2 structures. So this is a video of how we perform a regular inferior oblique resection. The inferior oblique can either be tackled through a fornicial incision, which is given infratemporally, or through a limbal incision. For the beginners, it would always be better if we can hook the lateral rectus muscle initially, which acts like a marker, and then followed by that hook the inferior oblique muscle. So this here we have opened up the fornix part of the fornicial incision, and this is the direct visualization of the inferior oblique. So if we look through that red bulky structure here forms the inferior oblique. If you want to make yourself sure, please do hook the lateral rectus. Make sure that you're not hooking lateral or the inferior rectus, and then go ahead and hook for the inferior oblique muscle. The hooking of the oblique muscle is usually done by a blunt Stevens hook initially, lest you damage those 2 important structures which I have already mentioned. Once you hook the muscle, you need to pull it up and see that white triangular structure which is below, which shows that the whole of the muscle has been hooked. The seeing of the white triangular tissue which is present between the 2 parts of the inferior oblique is an indicator that we can go ahead and proceed with the thing. If you don't see that, that means some amount of the fibers are still left behind. Do go back and search. Otherwise, the recession will never be complete and the inferior oblique overaction can still persist. So once that is done, isolate the inferior oblique from all the surrounding tenons and the tissues which it has been attached, and the inferior oblique, to perform the inferior oblique disinsertion, both the ways can be used. It can be cut and then it can be sutured, or it can be sutured and it can be released. Each surgeon has his own way of performing the inferior oblique recession part. So here in this procedure we have just clamped it. Remember, the oblique is very vascular muscle, so because of which the clamping to reduce as much amount of the bleeding, and then once you cut it, we have taken the suture. But the other way around can also be done, taking the suture and then cutting. So the recession there are basically three types of recession: the Finks, the Parks, the Elliott and Nankin. So for 1 to 2 plus, usually the 1 plus around Finks, 2 to 3 plus Parks, and if it is a gross 4 plus, Elliott and Nankin, and modified Elliott and Nankin, both of them are available. So where exactly do you place to hook based on what recession we are performing, we can go and take the bite of the inferior oblique to the sclera. I'm rushing through because of the short of the time. So measure, you can see the vortex vein over there, in fact, where you're taking the hook. So this is the mark where I'm performing the inferior oblique recession. I take the bite over there and I attach it. For the easier understanding, this is lateral rectus muscle, this is inferior rectus muscle. So the Fink's point is somewhere 6 millimeter beyond and 6 millimeter below the insertion of the lateral rectus. The Park's point is 3 millimeter below and 2 millimeter away lateral to the lateral border of the inferior rectus muscle, and that is used nearly for 2 to 3 plus. Elliott and Nankin is just beside the lateral border of the inferior rectus muscle, and that causes actually bunching up. It can result in something called a J phenomena because of this tight neurovascular bundle which passes through the inferior oblique and can result in anti-elevation syndrome. So use this point, the Elliott and Nankin point, only when you are seeing an inferior oblique overaction with unilateral SO palsy or with DVD. It will tackle both inferior oblique overaction as well as the hypertropia. Those cases where there is the extorsion is the main component, you can bring the inferior oblique and put it in the medial aspect of the inferior rectus, that is known as anteronasal transposition. The other technique which really I don't practice much is basically the inferior rectus inferior oblique myectomy. So it is, you need to cut a bit of the muscle before you actually, this is not my video, I don't personally practice inferior oblique myectomy. So it's not just cutting and leaving. If you cut and leave, wherever you leave, it goes and attaches over there and it can further cause an inferior oblique overaction again. So you have to remove 1 to 2 millimeter of the muscle when you are removing off the inferior oblique, so that even if it goes and attaches, it doesn't reform it into the actual muscle, but still over a period of next 2 to 3 years, and haywire inferior oblique activity can appear with a myectomy. So with this, I would like to say that inferior oblique is an enigma. Whatever we have seen till now is just the tip of the iceberg. There are still a lot of things, the vice plate, the strengthening, there are tucking, which are lot of procedures are still available with the inferior oblique. Time constraints have cut short this. So with this, I would like to end my talk here. Thank you once again. Fat adherence syndrome. SN still do, yes.